All right, all right. This is our third mashup of celebrating the Better Podcast in 2021. And we are doing a dive on hormones in this mashup. Now, this is probably one of the bigger topics that you'll hear me speak about, especially as it pertains to female physiology and why we need to, whether you are a clinician, which I know a lot of you are clinicians, you are just someone who is trying to live a better life and understand how her hormones, your hormones impact your life, or you are just a health seeker and you want to help other people, including yourself. This mashup is the best of the best. And we have some really heavy hitters in this show, and I'm really, really excited to go over them with you. And of course, this is a central topic in terms of what I teach healthcare practitioners, which is something that I have just recently started doing towards the second half of 2021 and just loving it. You're going to hear more and more about it in 22. But one of the things I want is to help more and more clinicians, irrespective of the designations that you have, to help more females and to be able to nuance protocols that are more, we'll call it male in their origin, and how to apply that to the female form. So the first clip that we have here with you today, one of our top episodes in the podcast of all time, Dr. Sarah Gottfried. And this clip is actually from the beginning of our conversation. Before we dive into hormones, before we dive into her book, Women, Food, and Hormones, which is what she was discussing for the majority of her time with me in this show, we started talking about other healthcare providers, namely other OBGYNs, as Sarah is an OBGYN, a practicing OBGYN. And how and not just OBGYNs, but other medical professionals really do seem to there's a subset of these practitioners that really do seem to dismiss hormone regulation as this airy-fairy silliness that is not to be embraced and or looked at, specifically when we think about estrogen dominance, when we think about a lot of some of the hormonal dysregulation that I talk about in the Betty Body, and as some of the guests that I will highlight here in this mashup on hormones, you'll see highlight as well. And it can be really frustrating, particularly with the OBGYNs. Now, I'm happy to name names if someone reaches out specifically and asks me, but in the name of keeping it classy, you'll know that you should be slowly backing out the door, potentially running, if your OBGYN or any, for that matter, any healthcare practitioner cannot explain to you how nutrition plays into hormonal dysregulation, how movement therapy and or stress management plays into it. And maybe we'll even take it a step further and say that these hormone dysregulations even exist. You'll often find them touting this party line of, if it exists without evidence, you can dismiss it just as easily. And of course, it's all about what you're willing to accept as evidence. Of course, as an OBGYN or someone who works in the hormonal space, like an endocrinologist, who often are also really big offenders, if there's not a drug that they can prescribe for it, you're often out the door, sort of being told that it's all in your head, and or it's part of aging, and or it's normal. There are a couple of really egregious offenders, I'll say, that will, in the name of dismantling the patriarchy, we'll talk about this idea that there's no such thing as hormonal dysregulation, and I'll just kind of leave it at that, because and some of these practitioners I've just simply had to unfollow, because they basically target people who do not have the same opinions as them and have named themselves as the regulatory body. They've taken it upon themselves to dismantle, discredit, and do whatever they deem necessary. Not their regulatory body, they themselves, their own personal opinion, what they deem necessary. So if you already don't have a clue of who I'm talking about, it's not that hard to find. But we're going to keep it classy. We're not going to hold names, but I'd love for you to listen to Dr. Sarah Gottfried, who good God, she's a goddess, like so elegantly kind of runs through why this type of pervasive thinking still exists in this allopathic model, where we have many doctors who will dismiss hormonal dysregulation. And unfortunately, you can't levy the blame entirely on them. It is the system that they've grown up in, right? It's the system that has taught them that if there's not a medication for it, or, if there's not a certain test that they deem is evidence-based, then it's worthy of just dismissing it. And so Dr. Godfrey talks about estrogen dominance in the context of course, obviously breast cancer. This is one of the areas that we know is very, I hate using the word science is settled because science never settles. It's an ongoing inquiry, but where there is a lot of theory that is able to withstand the test of time and be able to withstand inquiry around, when you run estrogen dominant, there is a lot of fallout that can happen from that. One of them is breast cancer. And Dr. Gottfried talks about this sort of as we are the only time that we're really concerned about hormones, truthfully, when we're thinking about the allopathic model proper, is when a woman wants to get pregnant. And it's like, okay, I totally get it. We're going to test the LSH and FSH and estradiol and all the things. But how about when a woman isn't looking to get pregnant? How about when she's just looking to feel her best? Because, we've all seen, and I say this with love, we've all seen, men go into, their primary, and they complain that maybe their primary is at lower libido or mood disorder, and they get testosterone right off the bat. So she talks about the metabolic hormone insulin and its role in estrogen dysregulation. So without further delay, enjoy this sort of preamble conversation that made it into the podcast with Dr. Sarah Gottfried.
I went through the same training as those very people that you're talking about who dismiss the idea that nutrition can affect hormones, that hormone dysregulation is part of the struggle that many of us as women have with weight. And we're all looking at the same literature. So in some ways, it's surprising to see these very blanket statements about the lack of existence of some of these conditions. Let's just take a few examples here, because I think that's helpful in terms of getting specific. So if we talk first about what I think of as dysestrogenism, so having an imbalance with your estrogen, usually having too much relative to progesterone, but it could also be, the type of estrogen metabolites that you have. What we know is that, John Lee originally coined the phrase estrogen dominance, and it was defined as the number of molecules of progesterone you have in your saliva compared to the number of molecules that you have of estradiol. And if there's an imbalance, if you have, less than a ratio of 100-1, then that is a suggestion that you have what he called estrogen dominance. But if you look at the literature, and I've looked at this pretty thoroughly, I've got thousands of citations in my book, and you look at something like breast cancer, oncologists are well aware that dysestrogenism, having an imbalance with your estrogen, is one of the primary causes or factors when it comes to breast cancer. So that's, I think, one example of the way that, in some ways, mainstream medicine misses the mark. So I had the same training. I don't fault these clinicians. I was told that you shouldn't check hormones because they fluctuate too much, just sort of throughout the day and day to day. And the truth is, if someone's trying to get pregnant, if a woman's, in her premenopausal reproductive age and she's trying to get pregnant, we check all the hormones, right? We look at estrogen on day 3. We look at FSH, follicle stimulating hormone. We look at thyroid. We sometimes look at cortisol and DHEA because we know that those are factors when it comes to fertility. So my feeling is that there's a double standard here, which is if you're not trying to get pregnant, we basically blow off this idea that hormones are part of metabolism, part of the energy that you create, part of these biochemical processes that you have in the body, and that it only is relevant to check them if you're trying to get pregnant. Now, I'm just going to call that patriarchal society, because I think that's part of the issue here. And it wasn't until I was in my 30s, when I was struggling with my own metabolic hormones, that I realized, okay, what I learned in medical school and residency isn't sufficient. I need to dive deeper here. And, you take a hormone like insulin, there's no debate that insulin is the most important metabolic hormone. And yet, how many mainstream physicians are actually measuring insulin in their patients? Very few. So I think there's a double standard, and that's what I hope to address with this book. I want to close that gap, because it's enough already with women suffering with their hormones and not getting the help that they need.
And here we have Dr. Felice Gersh. She is an expert in perimenopause and menopausal women, and an expert as well in hormone replacement therapy. And that is what we were talking all about in this, in our podcast together. And so if you want to learn more about bioidenticals, if you want to learn more about hormone replacement therapy, check out the full length episode. And I wanted to include this here because, one of the comments that she made, and this is sort of piggybacking off of Sarah's comment around sort of the problem with traditional healthcare, is she makes a comment that is, I'll paraphrase it, but you'll hear it in the clip, where she says, when we talk about natural, like, my job as a doctor is to play with natural, which I thought was just so true. And I thought it was very funny. And I wanted to include this in here. And she's talking about how essentially our cells actually don't know how old we are. It's just through the concentration of certain hormones. It's the capacity of our mitochondria that our cells kind of figure out what's up. So if we are, in this case, talking about bioidentical, hormonal replacement therapy or hormonal replacement therapy, if we are able to call it quote unquote trick our cells into thinking that they are younger. When we think about men, women in their reproductive years, we have much higher levels of estrogen than our postmenopausal sisters do. If we are adding in estrogen into the mix, then we can help our cells think, maybe potentially trick, not to use a word I don't enjoy this, but we'll say biohack, biohack our cells into thinking that they're younger. So enjoy my conversation with the wise goddess that is Dr. Felice Gersh.
So once you understand all of the different metabolic effects of estrogen, how it actually has a role in maintaining the health and function of every single organ system in the body without any exceptions, then yes, it's natural. And that's always been sort of like, it's natural. So why would you mess with natural? Well, guess what? I'm a doctor. That's all I do is mess with natural. That's what I do.
Cancer is natural. I mean, like that's sort of
right.
that's such a ubiquitous term, like natural, like, there's many things like aluminum, mercury is natural, like we don't have it.
My goal is, as a doctor, is to understand what it takes to help the body to function optimally, and then to try to keep it in that state at any age of life and through any circumstance, including like pregnancy, puberty, middle-aged, older age, whatever it is. And when you think about it, when is a woman optimally healthy? We're not talking about during pregnancy. It's really when she's like in her 20s. Okay. So then you think, what's the hormonal environment of the human body when a woman is in her 20s? Well, it's filled with estrogen naturally, so that's really what I want to maintain. If you think about it, no cell in the body actually knows how old it is. If you give it what it needs in order to do its job, all of its metabolic functions, its intracellular issues that it needs to take care of, if you give it what it needs, no matter how old that cell is, it'll perform. But what happens with aging is it's an accumulation of deficiencies. Once you lose your foundational hormones like estrogen and progesterone, I think of as also, of course, very important, and testosterone. There's no unimportant hormone. But if I create sort of a hierarchy, I tend to put estrogen at the the top, and then the others all work together. You need everything. It's like a recipe. Which ingredient do you want to leave out? Well, some may be more important than others. You can't bake bread and just leave out the flour, but maybe you could leave out the salt or something like that. Not that I'm a baker, but in terms of coming up with what could you possibly live without and still be, it tastes pretty good, or you're still really healthy. And unfortunately, estrogen is not really optional for optimal health once you really understand what it's doing throughout the body. So what I would want to do is to give the cells what it needs. So hormones are really messengers. They're information delivery systems. And so if you don't have that information coming into the cell, it won't do what is optimal for the body as a whole, for the organ that it's in, and then for the whole body that it's residing in. So if we can try to maintain something of a physiologic environment with our hormones for our cells, then we'll have a better functioning body.
All right. And then wading into the hormonal waters, we are talking about androgen dominance and estrogen dominance with Dr. Mohammed. He came on the show. He is the executive director at a company that I often use with my clients called the DNA Company. And in this clip, we are talking about different types of morphological presentations in a woman. Essentially, we're talking about the metabolism of testosterone and where that can go awry into androgen dominance, and estrogen metabolism and where that can go awry into estrogen dominance, and how that might play out in terms of a woman's morphological, her baseline morphology. Now, of course, that's not to say that you can't change the way that you look. Like, genetics is the first piece of the puzzle. And of course, your epigenetics through stress management and sleep and resistance training and nutrition can, of course, change the way that you appear. So for example, if you are someone who runs estrogen dominant, so you tend to deposit more of your fat through the lower half of your body, the quote unquote pear type of body shape, you can, of course, change that appearance through building more of an hourglass frame, which is what I talk a lot about, where we build up our shoulders, we widen our shoulders, we widen our back so that the upper part of our body can match the lower part of our body. And there's nothing to be, I am a pear, like that is my natural fat distribution is through the lower tummy, the hips, the bums, the thighs. I've often said my thighs never are not going to touch. Like, they're always going to touch. I'm always going to have a booty, whether or not it's in style. Like, I grew up in an era where the big booty was not in style. And then, of course, like, hat tip to J-Lo and Shakira and the Latin, sort of revolution, and the Kardashians as well, who've sort of popularized sort of larger, more rounder, we'll call it, behinds. As it goes out of style, which I'm sure it will, I will still remain with the same base booty, right? So here Dr. Mohammed is talking about androgen dominance, estrogen dominance, and then what the fallout is for each type of genetic predisposition to interventions like the pill, for example. So enjoy this conversation, fascinating conversation in general.
The female body has the ability to polarize, to have both androgen signal development as well as estrogen signal development. The male body has the same. Now, all things equal, the male body is designed to respond more to the androgen signals, less to the estrogen signals, the female body vice versa. But both body types, both sexes, and obviously we understand that there are things in between, but both general body types are going to respond accordingly. So as you've just noted, what we see in the androdominant female, that when she was in university, she was the soccer player, the triathlete, she can, all of the things that we can describe about her. But when she gets a little older, she wasn't watching her diet as much. And if she starts to put weight on, she'll put weight on in the more male-like feature. How many males do we see? They can still walk around with skinny legs, and whatever, but a big gut. They're not putting it on. They're not packing it on in the bum or the thighs. That's an andro imprinting because of how the abdominal fat cells respond when it comes to weight gain. And so that female that is androdominant for the genetic characteristics that we've just spoken of will have that type of morphology, behavior. But also, Stephanie, and we'll get into a little bit more of this nuance and finesse when we get into the metabolism of the hormones, these two young women can also experience differences to the length, clarity of and circadian rhythm of their hormone cycles. That more androgenized young woman, where she's not creating and converting her androgens into estrogens because her aromatization is lower, to say nothing of the fact that she was also more androdominant for all of the reasons we've said. She may, for example, start to experience irregularity to her cycles, and that irregularity is exacerbated much more easily if she were to become very athletic. How many female athletes, now look at here's which comes first, the chicken or the egg? Many times they're female athletes, and of course, depending on the sport in question, because they had a more androgenized genetic cascade as per what we've just described. And mind you, then, because of the stresses and the physical exertion in their bodies, which accentuates the androgenization of the body, and which creates a cortisol imbalance to the body, which therefore creates a progesterone imbalance, which therefore further androgenizes the body. How many female athletes, elite female athletes, miss their monthly cycles altogether? Why? Because their cycle now has lost the crispness of the peaks and valleys of progesterones, androgens, and estrogens, which you need the peak of estrogen and then it coming down to trigger ovulation and to trigger menses. When we begin to not flatten, but when we begin to reduce those peaks and valleys, pushing everything more towards androgenization, we do not get the circadian triggers that lead to ovulation and menses in those elite female athletes that are already androgenized, and their very lifestyle androgenizes them further. Case in point. The flip of this, the young women that are by nature much more estrogenized, because of the estrogen dominance in their body, they may see other menstrual cycle variances. They may be the young woman that, particularly the first group of young women, we tend to find missing cycles. We tend to find, especially based on lifestyle choices, they just might miss their cycles. They may be very light. They may not follow a circadian rhythm that is as clearly defined. That's your androdominant cycle, all things equal. Your estrodominant cycle, they may have cycles like clockwork, but they may start noticing that especially if they do not do something about extreme estrodominance, they start spotting a cool 5-7 days before their real cycle. Why? Because the clarity between their estrogen versus progesterone, that progesterone that you need enough of, which in estrodominance is quickly going from progesterone to testosterone to estrogens, you're therefore losing a different type of clarity versus the androdominant woman. She does not have enough progesterone to maintain the clarity of the uterine lining, to maintain the integrity of the uterine lining. So she starts spotting, she starts getting some cellular scuffing earlier, even before her real menses kicks in. So just by looking at this level, and we're going to go deeper for all of the listeners out there, just at this level, as Dr. Estima has pointed out, we can infer body morphology. We can even infer things like behavioral tendencies, proclivities to anxiety, proclivities to the concepts of PMS reside largely in what we've just said and some of what we're about to say. So we can define morphology and we can define what is happening in that female cycle. And one last point here is, Stephanie, can you imagine then when we take that ultra androgenized female per every genetic factor that we just said, and then we put her on the pill. In fact, let's take both roommates. So they're now 19 years old. They're off on their own. They're at university. And for the first time in their lives, they're both going to go on the pill. And so they go to the campus clinician who, after speaking to them, knowing their roommates, everything else, puts them on the same pill. And this particular same pill happens to be a slightly heavy dose or higher dose estrogen pill. The young woman who was already estrodominant, her going on that estrogenized protocol It will have, and it can have certain changes in her body. But what about that androdominant female? That from the time she was 11 or 12 to the time she's 19, those 7 years, her body was not at all anywhere close to being bathed in the levels of estrogens. And by the way, when you go on the pill, this particular pill, she's on estrogens, not for about the 7 days between days 12 of the cycle and, days 19, give or take. She's on an estrogen exposure for 21 days of her cycle. What do you think her body that was not seeing that level of estrogens, and therefore her cells were not behaving, her cells were behaving in a more andro feature phenotype? What is going to happen to her body, and how might her body respond when she's put on that pill? So the point here, before we go further, is, as Dr. Estima has pointed out, we can infer morphology, we can infer cycle differences and cycle normalcies and certain dysfunctions. We can infer how the body might respond depending on the birth control of choice. These are profound things, and they become even more profound, Stephanie, when we go to the next level.
All right. Coming up next, we got Dr. Carrie Jones. This was her second time on the show. She was on last year and then another time this year for a class that we did live inside my membership. And in this clip, she is talking about how stress can affect your menstrual cycle. And she does, Carrie is a teacher, and we know, of course, the word doctor, Latin for the root from the root word doctore, meaning to teach, is an excellent teacher. So I love her analogy around, as we reach menopause, where the ovaries are no longer, working anymore, the adrenals sort of look around like very similarly in a corporate situation. If you had, a vital member of your team quit, you're sort of left with taking up the task of the employee who left. And, she sort of parallels this with your adrenals, and, the adrenals, you can just kind of imagine them like kind of looking around going, hey, where's lefty and righty? Just love the way that Carrie explains things, and how we often don't make the connection between either acute stress or chronic low-grade stress on our menstrual cycle. And it is absolutely one of the primary factors in hormonal dysregulation, is whether or not your cortisol levels and or your HPA axis is in check. So without further delay, here is the great Dr. Carrie Jones talking about cortisol and our menstrual cycles.
When you are cycling, this is how I view it. So when you're cycling and even into perimenopause, your ovaries are still a fully functioning gland, or at least a partially functioning gland. And they are taking a lot of the pressure off of your other glands to carry their load of the work. So for those of you, maybe in your job, you work with a team. And so everybody on the team plays a role. And if somebody's on the team is not really doing their job, or missing, or retires, or quits, then either you have to pick up the slack or you have to hire for that position. In your body, you can't hire for the position. You can't. So once the ovaries do decide to retire, then the adrenal glands are like, where did lefty and righty go? Like, who is making estrogen and progesterone, and who's picking up the slack? Nobody's really picking up the slack, which is why the hormones drop so low. So you miss out on all that lovely, robust estrogen and progesterone that was helping so many things way beyond female health, way beyond making a baby. I mean, all your immune system cells have estrogen on it. Your estrogen is super critical for your brain, just like progesterone is, your bones, your joints, your skin, your heart, everything. And so now with menopause, as those levels drop from way up here to way down here, and cortisol and the adrenals and your adrenaline system is like, oh crap, they get more triggered, they get more sensitive, they react more, because you don't have the lushness of the estrogen and progesterone to help carry the weight with everything else. And so what I tell women is that when you're going through menopause, it's like reverse puberty. So if you remember all the, crap took to get you into puberty, and how awesome that was, and now imagine backing out of it. And so you need your stress health, your stress response, how you manage stress dialed in at that time, because it's a wild ride if you haven't gone through it yet, or you're not in it yet. And it in itself can be stressful. And then you add the world on top of it. You add your family, you add your kids, you add your job, you add the news, you add a virus, you add a pandemic, you add chemicals, intoxicants, and la on top of, and it's just the last drop in the bucket, and the bucket overfloweth, and you don't feel very good. So I 100% agree with you. When women ask me, at what age should I start with stress management? I'm like, yes. The earlier
yesterday.
The earlier, the better. When it's women in their 30s, I'm like, start now. I know you are at the height probably of creating maybe families or your job or your entrepreneurship or whatever it is. And you feel like, I don't have time for this, and I seem to be doing fine, and it's totally fine for me to burn the non-toxic candle at both ends. But trust me, if you continue it, it's going to make your 40s and 50s a lot rougher. And just like you do, I see it all the time in my patients who slam into perimenopause and menopause as opposed to slide or glide into perimenopause or menopause.
And Dr. Maritza Snyder, I have known Maritza for several years now, and she is such a powerhouse in her own right. And it's so wonderful, actually, as we've been preparing these mashups, for me to go back and look at all the amazing women that I've interviewed and have the pleasure of just knowing and having friends and colleagues in these women. And certainly Maritza is that. And here she is we were talking about the release of her book, The Essential Oils Guide to Menopause. And we are talking here particularly about the effects, again, of stress and estrogen dominance. So this is one of the classes, you might say, of hormonal dysregulation. Estrogen dominance tends to be very much dismissed by some of these more traditional allopathic, we'll call them stagnant and outdated healthcare professionals. And so Maritza is really talking about how in her own life, she really found that stress was her secret edge. And I totally resonate with this, because I, as a continuing to be a reformed perfectionist, used to think that the more stressed out I was, the better I would perform. And of course, I was just running myself into the ground. And in the race to the bottom, there is no winner. So here is Dr. Maritza's story and she very beautifully intertwines this again with teaching in terms of how stress and estrogen dominance are related.
One of my favorite things to say is you cannot green smoothie your way out of chronic stress.
Yeah. And
you can't kale salad your way. And now I know I just touted all the benefits of green smoothies and kale salads. I recognize. And will they help you? 100%. But and will supplementation support you? Can you give back to your mitochondria, because your mitochondria is actually the one that's making cortisol? Yes, you can absolutely take the alpha lipoic acid. You could take the acetyl L-carnitine. You can take the CoQ10. I can keep naming all the things that your mitochondria needs to function. But at the end of the day, if you're constantly in a state of triggering up the stress response system, you're going to constantly continue to keep depleting. Yeah. And we know that one of the biggest hormones involved, cortisol, is going to have a profound impact on so many other hormone systems inside of the body, including estrogen dominance. Absolutely. I think one of the things that a lot of us don't know is that we think about cortisol, we think about the survival hormone, which yes, it is. But then one of the number one jobs of cortisol is to regulate insulin. And when we have a situation where cortisol isn't working proper, like when it's overly, we're just firing it off over and over and over again, you are then firing off insulin over and over. So we're constantly crying wolf. And what we know, not to say that I'm not concerned about liver function and what happens with the liver and the gut when it comes to inflammation. But I always say that the number one hormone that women need to focus on when it comes to our 40s and beyond is insulin. Because insulin, we think about hemoglobin A1C as an inflammatory marker because of insulin resistance. And that is also showing us that insulin resistance leads to dementia or cardiovascular disease or cancer or, a number of different chronic conditions. And what a lot of us don't know is one of the biggest triggers for insulin resistance is going to be deregulated cortisol levels due to how we're managing stress in our stress response system on the daily. And what we don't recognize, I think, Stephanie, what you said is that anytime we find ourselves kind of like that, like we just get a text message or we're running late to a meeting or something's happening with our family or whatever that may be, the average woman can fire off the stress response system 25 to 50 times a day and just not even know it. And we talked about this. I in my 20s, I was addicted to stress. I leveraged it. I used to call stress my slight edge because that's when I felt that jolt of that little extra something that I could use to get through the rest of my day. And I just kept leveraging and buying against it until I had severe chronic fatigue. And so oftentimes, a lot of us, we're mistaking what we think is that extra something, that little extra energy, that extra jolt that we just got. That's adrenaline, right? And in order for us to have harnessed that adrenaline, we had to fire off the stress response system, the HPA axis, the hypothalamic pituitary adrenal axis. And once we get into a habit of pushing that button, we trigger it more and more and more. And initially we can get away with it. We could potentially get away with it for a decade, maybe even 2 decades. And we can kind of brush off symptoms as, just every day. That's how women are. That's just the way things are for us. But eventually it's going to start to show up. It's going to start to show up in prediabetes. It may show up in an autoimmune condition, or often I see it usually shows up in chronic fatigue and burnout.
Another person I felt like I have known for many years is Nicole Jardim. And I had her on the show, actually second half of this year. I think I had her in September or October. So not too long ago. And her book is an excellent How to Fix Your Period is the name of her book, is an excellent parallel really to the Betty Body. We've written about the same things. And it's funny because when I saw her book, I'm like, oh, she chose a pink cover. How interesting. And then I was really kind of like, my book's pink. And, sort of looking through her book, I was like, wow, we are really on the same page here. So I had reached out to her and asked her to come on the show and just instantly felt a connection to this woman. So in this clip, she is talking about the two, we'll call it the mother hormone and the bonus parent, pregnenolone, which a lot of people have never heard of, and DHEA, and what those two hormones do and why they're so important for estrogen and progesterone and everything, and testosterone, and why we often skip over these two. But she so beautifully and masterfully talks about this in her book and in this clip as well. So enjoy.
Cortisol and insulin are at the top. They're the queen bee hormones, and they really dictate so much. And like we were talking about, it's nice in that that a lot of the problems are just from one root cause, and it's usually the stressors in our lives and then the blood sugar dysregulation. So if you get those mostly under control, things will start to improve significantly. And with pregnenolone, I wrote about this because I feel like pregnenolone is this another unsung hero responsible for basically the production of all of these hormones. It's a precursor to everything, essentially. And yet nobody even knows that it exists. And people have said that to me all the time. What's pregnenolone? Is that progesterone? And so I feel so bad for poor pregnenolone. But yeah, maybe no one knows it exists. But it's incredible because it's a precursor to all of these hormones. And it also does a bunch of other things as well. It's really supportive of our mood and our energy and motivation. It's also really helpful for, other things going on with our brain function as well. Like I said, depression, anxiety, all of these kinds of symptoms that relate to our mental health are soothed by pregnenolone. It's supportive of sleep. And like I said, PMS symptoms typically are not going to be a problem if you have a decent amount of pregnenolone. I think with pregnenolone, what is is so good is that, when we start to, like I said, get our cortisol and our stress hormones under control, usually pregnenolone starts to sort itself out. And it really, I don't feel like, from my experience, it becomes a problem until later on, like when you're in your 40s for the most part. Like in your 20s and 30s, you're usually all good. With pregnenolone, what I think is important to remember is that we don't need to supplement with it, because I think that a lot of people think, oh, pregnenolone, amazing. It's the hormone that's going to make all of my other hormones. Great. I'll just take some of that. But it doesn't really work like that. For everyone who's questioning whether they should take something like that or DHEA, it isn't a hormone that you just take and then hope for the best, because there are lots of different hormone pathways. And depending on your genetics and what's going on in your life, you might make more of one hormone and not another. So it's really important to just keep that in mind and like work from the top down. So not be supplementing with something like pregnenolone unless you're working with someone.
Well said. You can't, I mean, this is like, what's the top? Can I take what's the top? Can I take like brain supplement and then like get everything from there? Like, is everything going to be okay if I just take pregnenolone to, will my progesterone go up? Will my cortisol regulate? No, as you said, there's genetic pathways. There's the epigenetics of how you are marinating those genes in your everyday life. That's going to direct certain pathways, certain preferences in those pathways as well. And
so true.
Yeah, let's talk briefly about DHEA as well. Again, I like how you call DHEA a bonus parent. Is that what you called it? Yeah, yes. Bonus parent. Yeah, what does DHEA do?
I know I called it the bonus parent because, it comes from pregnenolone, but then it does other things. So it's responsible for testosterone and estrogen. DHEA, I called it in the book, the fountain of youth hormone, because that's essentially what it is. It's so great in your teens and 20s and early 30s, and then it starts to go down, sadly. And also it has a bit of a seesaw relationship with cortisol, because they both come from the adrenal glands. And, DHEA sort of, if you have enough DHEA, it sort of reins in the effects of cortisol. So it's important to think about DHEA as well. And again, we don't really hear about these hormones.
And lastly, we started off and we will end with Dr. Sarah Gottfried talking about testosterone. This is something that I think most women don't put together. We assume that estrogen is phenotypically the hormone of women, that we must have it in abundance and more so than men. And that's true. But what's also true is that we have more testosterone than we do estrogen. We have less testosterone than the guys do, but testosterone is the most abundant sex hormone that women have in the body. And this is important because this is going to be vital for our cognition, for our sense of agency, for our confidence, our ability to take risks, our ability to build muscle, our ability to, or our desire for sexual interaction, our sex drive. I mean, sort of famous for that. And you'll hear Dr. Sarah talk about this in this clip where she's talking to one of her patients who is very obviously a very successful woman who walks into rooms of, lots of high rollers in that room. So there's a lot of pressure. And this woman, through Dr. Sarah's coaching and guidance and mentoring, has come to understand why testosterone is so critical and so involved in who she is as a person. And so I would love that message for you, Betty, as you're listening to this hormonal mashup, to really have reverence for each of the different hormones, irrespective of where you are in the arc of life, in the hormonal arc of life, which all women go through varying stages of, being in your teens and being pregnant and post childbirth and then menopause and then, perimenopause, et cetera, to just have a lot of reverence for the unique, we'll call it hormonal stamp that we have as women, that we are unique and distinct from our male counterparts who are also beautiful and are to be honored in their own way. But we know that the patriarchal, we know that living in a society such as the one that we do, we already know a lot about and how to support men. There can be an argument for how we can better support men, develop EQ and develop that emotional agency and how to identify feelings. But that is not my primary role to do. My primary role is to help my women understand their bodies better, so that when you understand that maybe you should be working out so that you can augment, so that you can lift up your testosterone. Or if you, nasal breathe, I know it's so funny to think like just nasal breathing is, versus mouth breathing is going to be better for your testosterone and better for your estrogen and better for your sleep and your stress reduction and your mitochondrial biogenesis and all the things. That is my role. That is, the role that I've taken on as an educator and as a doctor, for people in my podcast, people who and teaching my clinicians, teaching my doctors as well, so that they can bring it to their patients and to their communities. So without further delay, please enjoy this conversation or this clip with Dr. Sarah Gottfried.
A lot of women think that estrogen is the most abundant hormone that we have. It's responsible for our breasts and hips and about 400 other tasks in the body. But the truth is testosterone is the most abundant hormone that we have. So even though men have more, on average, about 10 times more, women are still exquisitely sensitive to it. So I just wanted to highlight that point that you made so beautifully. So testosterone is involved in so many different things. I think of it as a major multitasker. I was just talking to a patient yesterday who we've been talking about her testosterone for a while. She's a woman who's 52 and she's gone through menopause about 3 years ago. And she was saying, I think my testosterone is incredibly important to who I am as a person. And I agreed with her because she's a female executive. She's a risk taker. She has a lot of confidence. She walks into these rooms with Fortune 500 companies, and her testosterone, I think, is responsible for confidence, agency, definitely sex drive. That's, sort of what it's famous for. But it also is a major part of her sense of vitality, her mood, her stable mood, not feeling depressed. So what I see with testosterone is that some women start to decline, especially women who have been under chronic stress, toxic stress. We can see it begin to decline in the late 20s. So normally testosterone can go down about 1% per year after about age 28. That can be accelerated if you have excess stress. If that excess stress is driving up your cortisol and your insulin and you're eating more sugar, that can drive the testosterone down even faster and lower. So, some women just have this decline that it can occur way before menopause. It could be in their 20s, their 30s. Maybe they notice it when they're in their late 30s or their 40s, and their sex drive is just not what it used to be. Having sex with their partner is, if it even makes the list, it's at the bottom of the list. The other thing that we see is loss of muscle mass, so that you don't have, we talked about the hands with growth hormone. This is more your major muscles. So noticing that, maybe you're doing burst training at the gym and you're just not seeing the response that you would expect to see. That would be a cue to check your testosterone. So testosterone has its hands in a lot of things, some of which overlap with growth hormone, but some of which are unique to testosterone, especially vitality, agency, confidence, and sex drive.